we can go ahead and get started. From Intermountain Healthcare, I think I'm here to give a little bit of the healthcare system perspective on things. I want to talk a little bit about our efforts in telehealth as we go forward. And start really, as we try and start all of our conversations in Intermountain, with a patient story. So this is one of the first telehealth cases I ever watched being done by one of our ICU doctors. This is an 83-year-old farmer who was driven to the ER by his 81-year-old wife in rural Utah, had a skin infection, and he was beginning to develop a bloodstream infection, sepsis, over that time period. Usually, this is sort of the thing that happens. The local physician really think of large healthcare systems as a helicopter flying away. I mean, that's their vision of a big health system, is that that's that helicopter that flies away, and the patient goes into some sort of black hole and they don't really know what happens. And in rural communities, these people know this person's family. It's not like tomorrow at the grocery store, someone in the family isn't going to walk up and ask what happened to their relative, and they won't know because it's just a giant black hole for them. What we do now, though, and what happened with this patient, is that we keep them local. We try and keep as many people local as we possibly can. So if they don't have to be transplanted, I mean, all the equipment is there. All that needs to happen is that expertise needs to be flexed to the bedside. And it's critically important because support systems are local. Your family's local. Everyone in the community who supports you is local. It's better for patients to stay local. And we know that we can care for them well. We actually are able, in our rural ICUs, we decreased our mortality by 30%, increased the acuity ratio, and decreased the length of stay in those hospitals. And it's critically important for a couple of reasons. One, these hospitals are oftentimes the economic engine of their local community. It's really important for the local caregivers. If every difficult case gets taken away from you, you simply don't learn. So this allows local caregivers to learn, and it's not just the docs. Our ICU nurses teach the nurses locally about things to prevent cauda and clapsia and infection and all kinds of other stuff. So this is a tool to make high reliability medicine occur across an enterprise by teaching everyone in the enterprise the same protocols. So it's not just a care delivery tool, it's a learning tool, it's a reliability tool, it decreases costs as well. You don't need me to tell you about the expectation of our caregivers. Of our patients. I primarily use this slide to talk to physicians because they think that the expectation of their patients is to come see them. And that's not the expectations of their patients, right? Their patients expect Amazon. They expect to be able to get on their phone and get care because they can do it in every other aspect of their life. Ordering food, getting a car. If you grew up in my generation, actually your mother spent all this time telling you not to get in cars with strangers, and now I call them on my cell phone. So it's a very, very different expectation of life now, and we need to meet our patients where they are. That's the most important thing. If you're going to care for someone, you have to meet them where they are. You have to reach that me for them. So we have a platform called Connect Care. It actually has grown faster than anything else in Amwell's group. We use our own caregivers. Amwell provides the backbone for it. It's grown 6 times faster than any other program with Amwell at this point. We have a great star rating from our folks who use it. All 4 of my daughters, who are spread across the country, have used it. We have, at this point, almost 1.4 million people who are signed up as this is a benefit in their health insurance to be able to use it, and a relatively small investment. And if you think about this kind of investment, we've reached thousands and thousands of people, and we could have bought 1.5 hospital rooms in a conventionally built hospital for that. In fact, hospitals are probably the least valuable asset that most large systems own in terms of losing value. When I started in medicine in 1990, there were 1.2 million hospital beds in the US. And today, there are 800,000, which are only 60% occupied, and the population has grown by 75 million people. That's a market telling you that an asset is not as valuable as it was before. We're also redesigning how our primary care visits occur. This is the typical thing that would happen to patients. See the primary care doctor, go to the cardiologist sends you to the echo, go back to the cardiologist, and then usually the note from the cardiologist is lost, and you end up back at the primary care doctor's office. And this was set up for the convenience of only one person, which was physicians, right? Never for the patient, right? So what we've begun doing is telehealthing our specialists into our primary care visits. So single visit, even better, is to telehealth both of them into the patient's house. That's the way the care should be delivered to be efficient. Our organization has about 45% of our patients at risk. They're prepaid patients. This is the most cost-effective way to deliver care, by far. And if you're thinking about telehealth as a fee-for-service business, it is a good fee-for-service business. It's a phenomenal at-risk business because its cost structure is so low. So here's how we've sort of structured our services. We have our typical shared services folks who do all of our back office work. We have a provider support services, which is our transport, life flight, patient placement, all that. We have a hospitalist and ICU quarterback who sit inside that system for our acute care. They're the same people who provide our acute care services. So when you call for a transport, people decide whether you can stay locally or come, and that person will be caring for you if you stay locally. And they'll be initiating therapy before you get transported. So very important for that. We have our direct-to-consumer arm, which we talked about. Our Connect Care Pro is provider to provider. So we do that across hospital systems. We have about 34 hospitals that we care for in this network of folks. We are actively providing ICU and hospitalists and a whole slew of other services we'll talk about in a second. We also have a pediatric arm which replicates all that for peds. So these are the things that we have right now in our direct-to-consumer. We'll do Connect Care, which is just an urgent care visit. Primary care, we do tele-oncology, a lot of tele-oncology services because the Intermountain West is very spread out. With infectious disease, making sure we have appropriate use of antibiotics, wound care, lactation. We do a lot of simulation work, both for local docs and working patients through things. We don't ever let anyone get on a telehealth visit until they've done simulations. Should never have a provider do that until they learn how to do it and get a chance to do it in simulations. Pediatric services, mental health and rheumatology, endocrinology, dermatology, all those things that are hard to find are coming online this year. We have a lot of services inside the hospital as well. Our principal ones that we started with were really performing ICU care, neuro ICU, pediatrics. Do have a great neonatal resuscitation team that works across the Intermountain West, stroke. You can see the remainder of services. We're bringing on all of our hospitalists and psychiatry this year. Pharmacy, radiology, and path are coming as well. So our goal is really to help a hospital get better at their publicly reported measures. So we want them to improve in quality. We want people to follow care paths. We also want to measure our degree of human connection, so we get feedback from patients on that. The way to monetize this, for us, we have chosen to have a fee-based system or a value share. We have not tried to build directly inside hospitals. It's very difficult to do, and it doesn't have people focused on the same value elements that you want them to be focused on. So our goal is really to get people to 5 stars using this technology. We are looking for lots of partners, including all of you. This is not something that healthcare systems do well. We take care of people, we don't develop technology. What I would leave you with is this concept that the world in medicine has changed and there are new obligations. Anybody who could get to William Osler at Johns Hopkins could be treated. Anybody who's within the distance of a cell tower, I can treat today. There are 101.5 cell phone contracts for every 100 people on the planet. More contracts than people. We can reach virtually everyone. And now that we can, we have an obligation to reach them. Because before we couldn't, now we can, and as long as we can care for the people in our local area and care for others, we should. So I leave you this one portion of it, and this is really something I direct at traditional docs and health caregivers. And it's the most important part is this quote by Charles Darwin. And it's not the strongest person, it's not the smartest person, it's the people who can adapt to change who are going to be successful. And that's very hard for physicians in the dressed like me, in my me sense, to be able to do that. You all need to help them along that path. You need to remind them that they need to be flexible and that they need to change and adapt to the environment to take better care of their patients. That's it.
Thank you so much. I have time for maybe some quick questions. Okay.
I'm just super curious. As you break through the geographical barriers, what kinds of things do you have to contend with as a system? Because, you know, once you get rid of geographical barriers, you know, what's the limit, right, for you? How do you set boundaries?
So the biggest barrier are regulations. Credentialing and licensing are the biggest pain. Everything else is just like delivering care. And as long as you get your caregivers to do simulations and learn how to connect with the people who are there, both the patient and the caregivers who are local and their family and all those other folks, as long as you can train them to do that, the rest of it's just practicing good medicine. Yeah. Yeah, so I think the technology is definitely capable of addressing a global audience. I think the harder part, which is sort of the proof in the pudding for folks down the road, is that it's great to make connections with people. We have a lot of services that do that today. They do transactional interactions with patients. Almost none of them have any outcome data. In the end of the day, if you hold risk like we do, or you're paying for a patient to go, someone's going to want your outcome data. I think the biggest thing that will be hard for folks to do is provide that outcome data on a global scale, because these are distributed medical records all over the planet.
Hi. So I'm a physician informatics lead for a 24 hospital system that shall remain nameless. So I have a question. So if you were to compare this, you know, I was intimately involved in developing and then implementing Epic in 24 different hospitals, and you know the nightmare. You've been there, I'm sure.
It's actually posted in Dante's 7th level.
Exactly.
Right about here.
I'm at the 8th
You
level.
go in.
So how would you compare that to an implementation system-wide with a system like this? Because, I mean, I find this, I mean, I congratulate you. This is incredible. I mean, I can't even imagine this happening in our system. And I would love to know how you were able to accomplish that.
So for us, it was easier because we already were on one medical record. That's much harder than doing this. The key portions for this were just keeping it very simple. We have not tried to do a ton of additional monitoring or that sort of stuff. We focused on having a rock solid, reliable telehealth interaction by by video. Just working on that part first. That's 80 to 90% of the goodness, right? And it's actually very accomplishable in a place to do that. It's highly replicable. Once you begin to add more and more stuff on, which we're starting to now, it gets more difficult. The biggest issue is going to someone else who has another medical record. Getting the information that a doc needs to care for someone in that situation is more difficult.
So you mentioned that you had 1 million people that adopted customer care service. How long did it take to get that adoption? And what did you do to actually drive awareness?
So let me clarify that actually it's part of their health insurance. Okay. So they have this as the opportunity to do this. We're cresting about the 50,000 visit mark at this point. We'll be getting to the point where we're doing that in about a year's time too. So it's really rapidly rising for us. Actually, we did advertising, we did all that. Word of mouth is the most important part. Someone has a successful experience and they don't have to take their kid to, like I used to a pediatrician's office with 3 small children in tow. And you know, it's like jumping into a giant auger plate because everyone in the office is sick. You know, why would you want to bring your 3 healthy children there? So, yeah, word of mouth.
Thank you so much. Again, so you can mingle with the speaker during the breaks. And can I ask you one final
Sure.
question? Like, Intermountain is known for being really innovative, forward-thinking. You have done a lot of stuff. Is there something you learned that through your time that you believe that the rest of the world do not believe yet?
I would say that the rest of so there are 2 things. I believe that that the most money and most profitable portion in healthcare is in risk, not in fee-for-service. And anyone who doesn't think that this is the way that patients will be cared for, even in the very immediate future, has their head in the sand. And I will tell you that the vast majority of health systems, yes.
Thank you so much.
Sure enough, thank you.